Thank you very much, my dear friend, and thank you very much to the organizers for the kind invitation. I'm very happy to be here with you. And as you know, osteoarthritis is always the last disease that we consider, but we don't know why, because probably part of us have some osteoarthritis and have some pain related with osteoarthritis. So probably it's something that we don't pay so much attention, but it's something that we want to know at least how to evaluate and at least to know if there is a possibility to have a window of opportunity to treat osteoarthritis before we see image. I have no conflict of interest regarding this lecture, and my main objective will be describe the biomarker role of different imaging modalities in the structures that are involved in osteoarthritis. And what is osteoarthritis? Well, everyone knows osteoarthritis, but in fact, we know that there are multiple phenotypes of osteoarthritis. And this is not a disease of a single tissue. This is a disease involving many other tissues that we have in the joint and around the joint. What happened with the clinical evaluation is really very, very poor. It's indirect, it's based on symptoms, mainly on pain, because if there is no pain, the patient doesn't mind. So pain, swelling, and sometimes the muscle weakness, something like sarcopenia. That is a new concept that is not so new, but is more and more interesting every day. We don't have clinical diagnostic methods to do early diagnostic in osteoarthritis, and it seems that we are not so interested. So why? Because we have no treatment. So what you need an early diagnostic? Well, we'll see in the future. We have risk factors, and these factors are really poor predictors in a heterogeneous population with osteoarthritis, so they have not so much value in our diagnostic. And at the end, there are no cost-effective and non-invasive methods to assess the cartilage tissue quality and or the regeneration treatment. So what is the imaging value in this scenario? Well, early stages of osteoarthritis are potentially reversible. Then we have patients who have the risk of rapid evolution, patients with obesity, with acute injury, and we need a longitudinal evaluation in risk cohorts, meaning that we need to have some imaging technique to do that. Which kind of patient? Hip dysplasia, patellar dysmorphia, femoral acetabular impingement, and a long list of them. There is a relationship between imaging and symptoms when we have bone marrow edema, when we have cyanobitis, and where is a change in the cartilage thickening. What is curious is that imaging is not necessary to establish a clinical diagnostic of osteoarthritis, so we are wasting our time, we can leave. Well, not so. We have the X-ray, that is the modality of choice, is the one included in every clinical trial, but when you are using X-ray, we are confirming that there is a bony damage. This is from late stages of evolution. This is not for having this early window. And we know that we have patients who can have a structural progression. We have different phenotypes of osteoarthritis based on pain, based on inflammation, and based on many other different aspects of the disease. So can we do image of the different components of the joint? What about the cartilage and the fibrocartilage? We know that the cartilage is kind of lazy, let's say, tissue. We have this chondrocyte that is not so active. is making the extracellular matrix, is giving the collagen and the glucosaminoglycans. And every change that we have in water content in these cartilage is the early change that goes before having a cartilage loss, before having osteoarthritis. So the glucosaminoglycan evaluation can be a sensitive marker in the cartilage degradation. Every image that you see here belongs to my university. I am teaching anatomy at the university, and we have a very active department in doing dissections from imaging purpose, mainly for imaging, medical imaging. So what with MRI? We have possibilities with MRI to see modification in collagen and glucosaminoglycan matrix and changing that can be evaluated by semi-quantitative scales. We have also other techniques, 3D segmentation and composition techniques. Let me tell you one word about all of these kind of techniques that maybe you know. The MRI of articular cartilage is nothing new. We have different semi-quantitative scales that can be applied depending on your interest. Worms and blocks are the ones more common, but they are a long list of them. What about segmentation? Segmentation is something that we can do when we want to measure the cartilage and the meniscus volume. So in that way, we need to make parts and export this data in the three-dimensional image for the evaluation of the thickness and the volume of the areas of interest. And the composition techniques. The composition techniques, it gives you the clue of the biomechanical or the biochemical changes in the tissue, because gives us information about the volume of water, the proteoglycans, and the collagen. At the beginning, it was always with contrast, but today we have different MRI sequences that allows us to see MRI composition of the cartilage. And ultrasound, because this is in fact my area of interest, well, we can see the cartilage by ultrasound. And here you have the cartilage, and you see these excellent workshops that we had in the morning where they explain about ultrasound, and we know that this is hyper-echogenicity, whereas this is anechogenicity. Anechogenicity means no echo, and this is water. And water is the main component of the cartilage. So we can identify the cartilage by ultrasound, and the image of the cartilage is clear, as well as it's clear that the cartilage can have pathologies different from osteoarthritis, and we can differentiate by ultrasound. And this is the case of these patients having CPPD disease. We can measure the echo intensity. This is a topic of that is on discussion, but we can measure the echo intensity, and the echo intensity of the cartilage is associated with the arthroscopic findings in the medial femoral cartilage that is damaged after ACL injury. And the meniscus, the fibrocartilage, who has not problems in the meniscus? Well, we know the very important role of the meniscus as a shock absorption, load distribution, the improving joint congruence, also the having this role in collaboration in the proprioception, in lubrication. And we know that when we have meniscal degeneration, we can have more osteoarthritis, and the osteoarthritis is progressing in relation to meniscal tears, in progression to specific meniscal tears, mostly the posterior radials. The meniscal damage is also correlating with WOMAC, that is a score to evaluate the stiffness and pain in patients with osteoarthritis, as well as correlates with MRI cartilage scores. Can we see meniscus with ultrasound? Well, we can see not the full meniscus. Obviously, we can see part of the meniscus. We can see the body of the meniscus, and we can see only the external aspect. So we never say that we can do or we can diagnose tears, meniscal tears by ultrasound. But yes, we can diagnose meniscal subluxation. And this meniscal subluxation predicts radiological impeachment. So it's something that came before osteoarthritis. And what about ligaments? Can we do something with the ligaments? Well, we have this nice ligament that is meniscotibial, or the coronal ligament, that contributes to the stability of the meniscus. And their injuries are associated with meniscal instability, so are associated with osteoarthritis. And as you can see in the ultrasound image, where you see here, this is the femoral condyle, this is the tibia, and here we see this part of the ligament, whereas this is the semimembranosus tendon. So we can assess the ligament, we can see it, and we can evaluate not only this ligament, but also medial collateral ligament, that is the one that you see in this image. So this is femur, tibia, and medial collateral ligament. And this is extended view of the medial collateral ligament. Sorry, this is lateral collateral ligament, because I see here the popliteus tendon. So this is lateral collateral ligament. And this ligamentous degeneration is with the degradation of articular cartilage. So it's something important also to see. And we see that we can see that also meniscal degeneration, not only in the knee joint, but also in the hip joint. And what you see here is acetabulum and femoral head. And this part here, this more hyper-echogenic image that you see in both sides, corresponding to two different patients, are meniscal calcification, that in the case of the hip joint, the name of the meniscus is labrum. So there are labral calcification in both patients having hip osteoarthritis. What other aspects can we see? We see here muscle, and we see the quadriceps, that is the tendon and the myotendinous junction, as well as the patellar tendon and the Hoffa fat pad, that has a really relevant role not only in degenerative but also in inflammatory diseases in rheumatology. What we were doing, and it's submitted to publication, is also evaluating the muscle and the different aspects of the muscle sarcopenia. We were evaluating by ultrasound, gross anatomy, and by histology, and doing a scoring system that, because it's under publication, I hope you will see in a short time. About the periarticular bone, it's an increasing importance of the periarticular bone, where we can evaluate the trabecular bone components, and we know the importance of these vertical components in the sense of compression, and the horizontal ones that are the ones resisting the tension. So gives us some information about the mechanism of injury in the bone. And we can do the evaluation by doing this X-ray fractal, that we can see the trabecular bone as well as the MRI or CT or the DEXA that we use also for osteoporosis. The MRI is probably one of the best ways to evaluate this MRI texture analysis. Is really one of the potential biomarkers for knee osteoarthritis. The bone marrow is another important aspect, not only in inflammatory diseases that we know that is associated with a worse progression, but also in degenerative diseases. So in osteoarthritis, the bone marrow lesions that are quite complex are associated with the more worse prognosis of these patients. And what about the synovium? Can we see the cyanobitis? Yes, this is something that we can see and we can evaluate. And here you see cyanobitis. This is the suprapatellar recess of the knee joint that we are compressing. So when we compress, the fluid is displacing. In that case, it's a patient with effusion and some synovial hypertrophy. And synovitis has been also associated with a worse prognosis and with pain in our patients. And osteophytes, this is what the patient knows. The patient comes to you telling you that, oh, I have osteophytes, or I have these pegs in my spine, so that is terrible. And we think that we know everything about osteophytes, and they are quite mysterious. In fact, their composition is not so clear. And we can have these marginal ones at the joint that seems to be stabilizing, but at the same time seems to be making some troubles for the joint. Or we can have the central ones that seems to be more relevant. But anyway, they are predicting joint impingement in symptomatic osteoarthritis. Last thing, are the X-rays something that we should forget? No, obviously no. X-rays are inexpensive and available, and we can see osteophytes, we can see subchondral sclerosis, cyst, narrowies, and we have a lot of scorings, and if we don't know so much about the interpretation, that I think it's not difficult in the case of osteoarthritis, we always can check and look for one of these scorings, and that will be easy. But what happened is that they are low, they have low sensitivity to change. That happened the same with inflammatory diseases. They don't allow us to see in a very well defined thing the soft tissue, and they are in discordance with symptoms. Here is just to show you this, I think this is a fantastic images coming from Romer, published 2 years ago. This is the same patient and different positions of the knee joint, and you can see how this patient is having a really, really huge osteoarthritis, just changing the position. So that makes us thinking about the real value of osteoarthritis. So the joint that we are assessing the most is the knee OA joint, because it's the one that we have more standardization. When we assess that? Well, mostly in atypical presentations, when we have this rapid progression or we have a change in clinical characteristics. But also in very early patients. This is not written here, but this is something that we do always when we have a painful joint, or when we have this healthy person doing so much sport that you see that has a valgus or a varus knee joint, and you are expecting the osteoarthritis appear in some moment. The plain radiography still now is the gold standard, although probably that is something to change in the future. These are the positions that we ask for. Ultrasound or MRI, depending on what you have, are really the ones that can evaluate the soft tissue, and we use CT or MRI for bony changes, as well as MRI when you have really subtle anatomical abnormalities that you want to evaluate. This talk has many limitations. One is that I didn't speak about the artificial intelligence role, that maybe will be the next way to read an ultrasound image. or the use of various imaging techniques that are not mentioned in the talk. Thank you very much, and